In this chapter, we will be dealing with diastemas. This means small and large gap closures. As mentioned in the chapter Diagnosis, contrasts are a major problem. As soon as a contrast meets white tooth material, this is irritating. In this case, we're dealing only with small gaps. Nonetheless, the smile is falsified. The problem seems to be the contrast points, which do not appear suitable. The diagnostic on the right photo demonstrates what the lip would look like without the contrast. Preparation was hardly performed in this case. On the one hand, the gap had to be closed. On the other, the tooth proportions needed reconstructing. In addition, a slight shift forwards was undertaken to round off the tooth arch. Then also complete this line again. And if the gaps in the center are in the middle, continue to the lateral teeth. It makes sense to close these gaps first, to mesial, and then to join up the teeth from lateral to mesial. This way, the tooth proportions can be retained. This is not a problem with a simple case like this, and the gaps can be closed readily for the time being. This was started from the gingiva, and note the depth of the papilla is still present. In this case, one can work epigingivally, either with a curved or a straight matrix. One could also have used a straight matrix to first fill the gaps in the background with dentine mass. Subsequently, the componeers would have been placed. However, what we see here is an uneven gingival level. In principle, this only concerns the cervical contour of the componeer. To make sure it fits the proximal space and the cervical area. Everything else can be adapted at the end. Now that the teeth have become a bit wider, the componeer M expected for the middle teeth would be too narrow. Because of the mesodistal width, a componeer L was used to cover the surface entirely. The componeer L are then, of course, too long, but they can be shortened. Tooth proportions are always distorted slightly in the case of diastemas, but one cannot retain the proportions in all cases, otherwise the teeth would become far too long. Nonetheless, the smile line is completed in the end. One can also see that the central incisors now follow the contour of the lower lip. On the right side, we had to stay a little bit short of the lower lip, as this would not have had a pleasing appearance. In brief, everything has to match: upper lip, contour of the bridge of the nose, bipupillary level, and often the upper and lower lip do not have a congruent shape. Here one can see that the upper lip has a slight deviation to the top left. A further example for a slight diastema. The gap between the ones is only minimal, but it is a butterfly situation. There is a curvature in the teeth which actually does not fit the upper lip. In the upper lip, we have a relatively pronounced philtrum. This is curvature of the upper lip, and the teeth behave in exactly the opposite way. It would make sense to adapt the teeth to the upper lip. Here too, it was possible to close the gap with a straight matrix. There's no need to penetrate subgingivally, as the papilla is at its maximum level. In principle, this end-to-end gap had been closed, and the incisal edges were extended somewhat with dentine mass, as things would otherwise have become too translucent. We can see the placed dentine and the componeer placed on top. In the case of smaller gaps, one should always take care to work with as little excess as possible. So if a componeer is placed, it is important to adapt or remove the excess composite material between the matrix and the componeer. Otherwise, this would result in a fine line of non-optimal material in the interspace to the next componeer, in other words, a border zone. On the right, one can still see a small gap between the 2 and the 3. It makes sense to fill or join this completely. However, we would not build up the 2 as this would otherwise become too wide. Instead, the 3 is built up mesially and thus shifted forward slightly. This allows retaining the proportions as naturally as possible. The incisal edges can be left as they are temporary. Subsequently, they can be checked again, and any changes can be marked with a pencil and finished. At the end, the margins are finished, and the surface contours made a bit more vibrant. Here we can see the surface of the tooth. We have introduced a structure. In the final outcome, one can see the corrected inverted line as well as the removed ugly contrast lines and contrast points. So far, we have encountered no problems, but there are situations with several gaps and partly also with malposition of teeth. This occurs often as the teeth have no orientation as to where they should be without proximal contact points. In this case, there is no abrasion on the incisors. They are extremely pointed. The lateral incisors are conical teeth. Approximately a third of the mesodistal diameter is missing. At the same time, the central incisors are formed more like tubs. In the cervical area, respectively the cervical third, the front tooth is nearly wider than at the incisal edge, which is normally not the case. In the diagnostic, one can see how much can be built up for each tooth. Generally speaking, one always closes up to the center. The same procedure is applied to the lateral incisors. If one closed both gaps of the 2, in other words from the 2 to the 1 and the gap from the 2 to the 3, then the 2 would be too wide. Therefore, the cuspid is built up palatal with dentine mass. These are the results from the diagnosis, and this is what it looks like. The base in the background was built up. The gap has been closed toward the center. The 2s were widened and the 3s also widened somewhat in forward direction. Then the componeers can be placed with the appropriate proportions. In the end, some slight adaptation is necessary, and this is marked with a pencil. Then the proportions are correct. The same applies to the mandible, and the gaps were also closed. One can see that the teeth in the maxilla have become slightly longer. This allowed retaining the proportions in the mandible, where it's often not possible to become longer. In this case, one can see a fanned-out mandibular front. Here, the mandibular anterior teeth have tried to be in contact with maxillary anterior teeth. One can also see the small abrasion corners on the mandibular anterior teeth. These cannot be elongated. For this reason, the mandibular anterior teeth would appear too wide in proportion when closing the gap. Here we can see a similar situation, again with a diastema in the middle. However, we already have a larger gap centrally. The papilla is already somewhat wider and at a deeper level. The diagnosis shows us our objective. Build-up is towards the center. The lateral incisors here, you can see through the translucency, need to become somewhat longer as well as wider. The shape fits the componeer well. First, build up towards the center was performed, followed by placing of the componeer. The proportions were largely retained. Of course, the teeth in the cervical area are somewhat wider, but this does not become obvious during normal smiles. More difficult are the diastemas following orthodontic treatment. In this case, the patient still has a retainer. This often creates difficulties when building up a base from interdental to buccal. One therefore only has the option of building up interdentally, starting from the tip of the papilla. Nonetheless, this can be achieved with a small piece of matrix in order to be able to finally close this gap completely. It is quite amazing how many people have gaps. Everywhere where either teeth are missing or where there's too much space, as shown on the X-ray. Here we do not see fewer teeth, they simply have too much room. The basic principle is always the same. A base needs to be built up first. Componeer cannot do this on its own, particularly when there are pronounced diastemas, as in this case. The situation shows a pseudo-pocket. The papilla has shifted slightly backwards, and we have a pseudo-pocket between this papilla tip or papilla height and the cervical attachment. To be precise, we have too much gingiva for the tooth crown. In such situations, it is an advantage if the gingiva is really completely healthy. It is virtually a prerequisite that patients are conditioned and that the gingiva can be maltreated without the risk of bleeding. It must be possible to place a retraction cord in this pseudo-pocket, this sulcus. Here we can see the retraction cord, which is somewhere at this level in the depth of the pocket. Why do we need this? To close such larger diastemas, we need a contoured molar matrix, in other words, a piece of matrix. One can cut this to size oneself. Contoured because we need a special cervical contour. We would like to achieve over-contouring of the tooth. This is rather difficult with a straight matrix, as this could only make a straight connection. The triangle would not be closed. One pushes this matrix along the tooth surface up to the retraction cord. The matrix is then jammed between the retraction cord and the tooth surface. In this situation, the primer is of special advantage, as we cannot work in the depth with phosphoric acid. The primer lets us condition the surface without irritating the gingiva. This way, the gingiva does not start bleeding and also shows no irritation when primer is applied. Once the matrix is jammed between the retraction cord and the tooth surface, the composite can simply be pressed down. One really presses it into this interspace between the matrix and the tooth. The excess composite will ooze out in buccal and palatal direction. But interdentally, where the matrix is jammed between the cord and the tooth, we only create an over-contour. This is the same principle as in implant dentistry, where a crown is built upon a thin post, yet still leaving a papilla or papilla-like structure visible. This photo was taken approximately 1 hour later. The papilla slowly adapts to this contour and begins to transform itself. 14 days later, the gingiva has more or less adapted completely to the tooth structure. Here it is important to again rework and finish cervically. Even if bleeding commences, it makes sense to rework this marginal area with an oscillating file or similar instrument to avoid any excess. Over-contour is good. Excess is counterproductive.